Hello, everybody, and welcome to the Ask the Expert session on atherosclerotic cardiovascular disease, also known as ASCVD. I am Jean Cannon. I am the moderator for today's session, and I have the privilege to introduce today's panelists. I'm going to begin with Professor Kaushik Ray, who is the Professor of Public Health, Department of Public Health and Primary Care, Imperial College London, and Honorary Consultant Cardiologist, Imperial College NHS Trust. Professor Ray is currently President of the European Atherosclerosis Society, Chair of the World Heart Federation Cholesterol Roadmap 2021-22, and Chair for the Global Council for Heart Health. He's also the national lead for the cardiovascular disease for the NIHR Academic Research Collaboration and Clinical Director for Discover Now, the Health Data Research UK Digital Innovation Hub. He received his medical education at the University of Birmingham, his MD at the University of Sheffield, a postdoctoral fellowship at Harvard Medical School, and finally, a master's in philosophy in epidemiology from the University of Cambridge. His research involves lipids, diabetes, and population health, serving as a global lead for trials and registries. He has more than 100,000 citations, and since 2018 has been recognized as among the top 0.1% of authors in global medicine. Magdalena Decor is Chief Executive of FH Europe, the European Patient Organizations Network, supporting and advocating for patients and citizens with inherited lipid conditions. Those include familial hypercholesterolemia, FH, inherited high cholesterol, and its rare and severe form, HoFH, as well as elevated Lp(a), which lead to premature ASCVD. Before joining the Pan-European charity, she led the EMEA region operations at the Drug Information Association. Prior to that, Magdalena worked for many years in different roles at an orphan drugs pharmaceutical company focused on saving lives of patients with rare and ultra-rare diseases. Magdalena is dedicated to making a positive impact for people affected with genetic cardiovascular diseases through effective public health advocacy, including prevention, screening, and early detection, access to treatment, family-based care, and health literacy. She's also highly involved in patient-centric and patient-driven support initiatives. And finally, Neil Johnson is Chief Executive of CROI, the Irish Heart and Stroke Charity, and the National Institute for Prevention and Cardiovascular Health in Ireland. He is founder and executive director of Global Heart Hub, the first international alliance of heart patient organizations, providing a platform to unite the voices of those living with or affected by cardiovascular disease. He holds a master's degree in psychology and is an honorary clinical fellow of the School of Medicine, National University of Ireland, Galway. Welcome to all of you.
Thank you.
So as I mentioned, we are going to be talking about ASCVD. ASCVD, as we know, is on the rise around the world, yet very little is known about it. Today's discussion will focus on, among other things, the need for advocacy and awareness. We will open the session with you, Professor Ray, who will help frame our discussion so that we can better understand from a global perspective ASCVD, its burden, the implications, consequences of the disease. So with that, I invite you to say a few words.
Jean, thank you very much. So the biggest problem with atherosclerotic cardiovascular disease is the silent nature, and the first time often somebody is aware that there is a problem is, for example, when they present suddenly with a heart attack or they die suddenly. Now we think about cardiovascular diseases, and essentially that means diseases of the heart and the piping that pumps blood around the body. So the vasculature, as we call it. Most common within that, there are valve issues, there are heart muscle issues, but the commonest thing is the process whereby slowly over time, we get furring of the blood vessels, and that's called atherosclerosis. And when it presents all of a sudden with a heart attack or a stroke or furring of the blood vessels to the legs, we call that peripheral arterial disease. It means that these are people with slightly more advanced disease or a greater vulnerability. Now, the issue is there is no single risk factor that can define who is and who isn't going to develop this over the course of their lifetime. There are some individuals, and you hear about that a little bit later on, that are inherently born with a single isolated risk factor, an extreme elevation of cholesterol. There are other people, for instance, who have a high-risk condition, like diabetes, for example, or chronic kidney disease, that predisposes them, accelerates this whole process. And globally, there are probably about 35, 40 million cases that occur, of which about 1/4, 25% occur in people with pre-existing disease. So if you like, we have to think about different approaches. Firstly, to try and prevent this from happening in the first place, what we call primary prevention. And then there are those people who've already manifest themselves as having this, who now we focus so much on taking them to hospital and treating them and putting balloons in, widening the arteries, so they're now asymptomatic. And we let them go back out into the world where essentially they feel fine again. But the same factors that cause the problem are still there. And it means these people have to be treated much, much more aggressively. And it's very easy to let things slide and let things slip. So we have different approaches. Secondary prevention patients have to be treated much, much more aggressively to try and reduce or normalize life expectancy, improve quality of life and their symptoms in the future. So that's really what ASCVD is in a nutshell, and the different approaches to try to manage this.
So can I ask you to explain a little bit more, who is at risk for ASCVD and why are so many people not aware that they're at risk?
So the main reason, as I said, there are going to be some people who are genetically more vulnerable to not necessarily abnormal levels of risk factors. So if you think about risk, essentially the risk factors, we can break them down into modifiable, non-modifiable. So women, lower risk. Women tend to develop heart disease and strokes later in life than men, partly the protective effects of hormones. As we age isn't a risk factor. Age is just the number of days you've been at risk, for example. There are certain ethnicities that seem to be inherently more vulnerable to the environment around us. But once you take those away, what we call in terms of modifiable risk factors are things like high levels of bad cholesterol, low levels of protective factors, so-called good cholesterol, diabetes, blood pressure, smoking, and there are new and emerging risk factors. There's something called lipoprotein (a), and there's also inflammation as well that accelerates this process. The vast majority of people will not have extremes of any one of those, but they will have combinations of little bits of all of these. And if you predispose that, if you like, on a genetically vulnerable environment, then these are people that will manifest early in life. And the issue is all of these things are silent. Having a higher or lower cholesterol or blood pressure doesn't make you feel any better, doesn't make you feel any worse. And that's part of the problem.
Thank you for that introduction. Magda, I wonder if we could invite you to say a few words. So Professor Ray has talked about, explained to us, who's at risk, including those living with non-modifiable ASCVD risk factors. And I know that that's a population you are familiar with. So what can we do as a community to improve the situation for people living with FH and other genetic dyslipidemias?
Hello, everyone, and thank you for the introduction, Jean. Before I expand on what Professor Ray has just shared with us in the context of a specific condition, I would like to thank the Global Heart Hub team for putting this very important event together and for the invitation to be part of a bigger and so much needed movement to beat CVD, and here specifically ASCVD. Having participated in the sessions yesterday, I wanted to congratulate and to thank speakers for being very inspiring and informative. I hope that in my short intervention, I'll be able to actually bridge to what was said yesterday. So today, indeed, it is my privilege to represent the voice of patients as well as citizens affected by inherited lipid conditions, which leads to premature ASCVD. As Chief Executive of FH Europe, the Pan-European Patient Organizations Network, I would like to highlight that our organization is indeed supporting patients and advocating for people with inherited lipid conditions, but not exclusively FH. Professor Ray has mentioned that there are also other conditions. So FH, elevated Lp(a), HoFH, about which I will speak in 1 second. Focus of my intervention today will be specifically FH, and people listening could say, FH what? Those two letters stand for familial hypercholesterolemia. A bit of a mouthful. What it really means, it's inherited, running in the family, very high, dangerously high, elevated, as Professor Ray said, cholesterol. And we specifically referring to LDL cholesterol, the so-called bad cholesterol, running in the blood. And I actually allow myself to pause here very quickly and ask anyone tuning in if there is anyone at all who has never heard of FH before. If so, please do me a favor and put in the chat a simple no. Because let me say, FH is the most common genetic CVD risk factors. It's actually so common that it also has a rare form. So quickly about FH, I think it's important to put it into perspective and build on what was said previously. Heterozygous FH affects 1 in just over 300 persons, as the recent meta-analysis indicate. It can be more frequent in some parts of the world. It occurs because of a mutation in 1 gene inherited from 1 of the parents, and it leads to increased LDL. And undetected and untreated accumulation of cholesterol leads to some serious consequences. The whole topic today, ASCVD. It presents, as mentioned earlier, chest pain, heart attacks, premature heart attacks, stroke, even sudden death, and that can occur as early as 30. However, if identified, the consequences can be successfully prevented and or managed with the use of available drug therapies. On the other hand, we have HoFH, the homozygous form that affects people who have inherited 1 and the same faulty gene from both parents. It is rare and far more severe. It's important to understand that the first-line treatment that we would use for FH would not be sufficient, and it affects people early, very early in childhood. Previously, in a few years back, there were some very dramatic cases of toddlers dying of heart attacks at the age of 4 in the Netherlands. So when we talk about FH, it is really important to remember that it is a very common condition, yet it has a rare form. And so it is often mistakenly considered as rare altogether because the general awareness about FH is very low. And that is both among public as well as, I have to say that, clinicians, especially pediatricians and general practitioners, so family doctors. Let me show you something really, really disturbing. FH is a huge challenge to tackle. Despite being the most common genetic condition in the world, it is seriously undetected. It is estimated there are over 30 million people living with FH globally. And let me say it, let me bring it home a little bit closer. Every minute, a child with FH is born. Every day, a child with HoFH is born. And still only 10% of affected individuals are diagnosed, meaning 9 out of 10 people are not aware of, as Professor Ray said earlier, silent, invisible condition they have. And let me just say it, it's a ticking bomb which might explode at any moment. 1 in 17 heart attacks suffered globally is as a result of FH. So how is that possible? FH is fairly easy to detect and to manage. We can live fairly happy, fulfilling life. And as long as we adhere to the treatment, as long as we are complementing it with healthy, low cholesterol diet, physical activity, and as earlier said, no smoking. Yet we live in a world where cholesterol is misunderstood, where admitting to having a genetic condition can be actually dangerous. Many people I meet are actually not willing to come forward and speak about the condition they live with. FH is invisible most part of one's life until it strikes. We are dealing with low awareness, as previously said. And so it is a bit of a vicious circle. Too few people know about it, and those who do know are not necessarily speaking about it. And in addition to the reasons mentioned earlier, there is also this notion of patient who wants to be constantly reminded about the fact that they have a genetic condition. What's the incentive to going out there and publicly talking and sharing? Only few people who live with FH feel the urge to go out there and advocate, to expose themselves, to share their tragic, very often family stories, and relieve the pain of losing a family member or even family members. And
I do know you have some slides that you want to share with the participants. It would be lovely if you could pull them up.
Can you see them now?
Yes, absolutely.
Fantastic. And I think I was so excited about speaking about the topic that I actually forgot 2 years down the road in COVID to share my slide. Apologies.
No apologies necessary, but I just wanted to also let you know that we're hearing a lot in the chat about many people who have not heard about FH. So you are headed in the right direction with sharing information. So please do continue.
Fantastic. Thank you for sharing that with me. So as I was mentioning, it is a bit of a vicious circle. People do not share about it. And so we cannot raise awareness. If we do not raise awareness, there is no effective ways of identifying, detecting those people and effectively helping them. There's one other thing that is really important to mention when we talk about cholesterol. There is this misunderstanding that it is due to our bad lifestyle. And I hope you've picked up from what Professor Kosh Ray was saying earlier. We are dealing with a non-modifiable CVD risk factor. It's genetic, it's inherited. You were born with that. So what needs to happen next is we need to build almost like an army of ambassadors. FH needs more people talking and sharing about it. And for those who might have seen the presentation yesterday by the Good Lobbying team, I would like to introduce another term. Next to the activists, advocates, and the lobbyists, we need another group of people, ambassadors. And at FH Europe, we engage with patients and their families to help raise awareness and to educate through sharing patient stories, focusing very much on the positive aspects of lives to help demystify FH. Here in the slide, you can see an example of a campaign we did, Many Faces, One Heart. We launched it on the occasion of the Rare Disease Day, focusing initially on the rare form of FH. And we continued on the day of International Women's Day. We actually wanted to explain how FH affects in particular women. And again, Professor Ray mentioned that women have a certain protection layer thanks to the hormones. However, again, this can be misunderstood, and female audience being in this room here might probably agree with me that very often they are diagnosed late, or for many years they are misdiagnosed, suffering from certain conditions. So let me just mention once again, we need more people, we need more educated patient advocates, but that's not enough. And I will come back to that in a second. On the occasion of the FH Awareness Day, which falls every year on September 24th, we engage experts. And when I say experts, I actually mean both patients and clinicians, as well as lay public. This is as well why FH Europe is building alliances and collaborations like the one today. I am absolutely honored to be on this panel together with Professor Ray from EAS and EAS FHSC, the Global Registry, as well as another fabulous ambassador and an advocate, and I dare saying a very good friend, Neil from Global Heart Hub. We need to expand. We need to be more daring. We need to make sure that more people know about FH. And our job in advocacy is to enable it, to facilitate it. And starting from 2022, we will kick off a patient ambassador program. Yet, to break this vicious circle, our community needs something more systematic solutions. And with that, I would like to share a little bit more about what we can do.
Magda, I wonder if you can speak a little bit about how important it is to work together to achieve advocacy.
As I said, I was sharing this slide with percentages. The most common genetic disease in the world, but only 10% of people being diagnosed. How is it possible, despite the knowledge, despite the treatment available, despite the global registry and the data that we have? It's extremely important to work together to implement systematic solutions. And so in case of FH, it's approaching screening and detection in a different way. Back in October, we, together with the Slovenian Health Ministry and many other experts around the world and patient organizations and our partners, among them mentioned previously EAS, EAS FHSC, as well as Global Heart Hub, we delivered a technical meeting to the European Union. For those who are joining us from outside of Europe, it's important to understand that we have a potential to actually reach some of the policymakers on a pan-European level and encourage them, inform them, as well as work together to implement health policies in public health space to introduce solutions like early child screening. And that's exactly what we're doing. It is extremely important that, like said yesterday by the Good Lobby team, we engage the patient community, the citizen community, as well as policy groups, politicians, to influence and change policies. It's not acceptable in 21st century that we have accepted heart attacks and strokes as a result of something that's preventable. Collaboration is absolutely key. One last slide. FH Europe is a network of patient organizations. We have members in 28 countries. Apart from that, we work closely with other pan-European and international patient groups, and recently established Alliance for Cardiovascular Health, in short, EACH. And you can see at the bottom the logos of other 17 organizations that came together to jointly fight and advocate to beat CVD, to change the situation, which is absolutely unacceptable. That's all from me, and I really hope that this hopefully will be motivating to build international, global, pan-European initiatives to work together to stop and to prevent what's preventable.
Thank you for that, Magda. It certainly is eye-opening just to even see that so many people are not aware, not familiar with FH. Before I hand over and introduce you, Neil, I just wanted to say there are a couple of questions that are coming in through the chat. There will be time following Neil's presentation. Do keep your questions coming. We are keeping track of them, and we will absolutely ask our panelists the questions that do, if we can, time permitting, the questions that do come in. And now, Neil, just to continue the conversation about ASCVD, I know that more than 300 million people are at risk with ASCVD, with another 300 million are living with ASCVD, with another 2 billion at risk. And I understand that the Global Heart Hub has embarked on a program that addresses the global threat ASCVD presents. I invite you to tell us more about this program.
Thank you. Thank you, Jean. And it's a real pleasure to follow on from Prof. Ray and Magda on this very important topic. At the outset, Professor Ray spoke about this being, a silent condition. And in a few moments, I'm going to share with you my thoughts about it being also an invisible condition. And he shared with us the scale of this condition, ASCVD. You've just made reference yourself, Jean, to the fact that there are an estimated 300 people living with ASCVD, about 15 million deaths per year globally from this condition, and 85% of all cardiovascular deaths can be attributed to ASCVD. So if an alien was to come down to our planet in the morning and look at these numbers, he or she couldn't but be shocked at the scale and burden. But then if you said to this alien, but actually 75 to 80% of this is preventable, he or she would clearly be stunned, notwithstanding what we've just heard from Magda, which is equally very disturbing, that a proportion of ASCVD is a result of a pre-existing genetic condition, which we can detect and which we can treat. So there is this lethal condition, estimated at 1 in about 300, give or take, which is easily detectable. And when you find one index case, you just don't find one person with this, you find multiples in a family, and the condition is treatable. So from the Global Heart Hub point of view, we're beginning to look at this and take it very seriously. And in that context, I want to share with you, I believe, what is an ambitious program, which we've just recently launched, and I hope will be a multi-year program to bring about the type of change that I feel is absolutely necessary to address the burden of ASCVD. So I want to talk to you about Invisible Nation, which is a program that was created with the objective of challenging the status quo and activating change around the world. And when I say the status quo, I think we've got to a point where across the world, we've just become too complacent about cardiovascular disease. And maybe by putting a spotlight on ASCVD, we might be able to reignite a conversation about this in a different way. Because if you take the umbrella of ASCVD, or of cardiovascular disease rather, the term we always use to describe anything from atrial fibrillation to valve disease to ASCVD, we use this term heart disease. But if we put a focus on just one component under that umbrella of ASCVD, and you look at how much of it is preventable or treatable, maybe we can reframe the conversation. And sometimes, in the advocacy world, the cardiac disease discussion is very often compared to the cancer discussion, for example, and we're told that, well, cardiac diseases are not really a motive. But in reality, ASCVD is the cancer of our world, because this is an insidious, slow-burning condition. And as Prof. Way mentioned, you have people who are treated by PCI or whatever, and they become, as a result of the treatment, asymptomatic, but they're still living with the condition. And we need to ensure that that condition is properly managed over the long term. So Invisible Nation is basically a call being led by the patient community, a call to raise awareness of ASCVD as one aspect of cardiovascular disease, and that unfortunately, globally, nationally, locally, there seems to be almost no understanding of the burden it represents to healthcare systems, and of course to people living with ASCVD. And together we're hoping to drive change, but the change is ultimately going to need to happen at the level of healthcare systems. And so what I think is interesting and important about this program is that it's patient-led. And so it's from the bottom up. And we want to reach ultimately the voices of the influencers. And so I am calling on the patient community to join forces with us and to be advocates for the Invisible Nation project. After being exposed, hopefully, to the Invisible Nation campaign through the patient community, we hope that decision makers, policymakers, and stakeholders will focus on creating better conditions for better health outcomes for people living with ASCVD. Now, this is not something that's going to happen overnight. And as I say, we've just launched the campaign. We're building the alliance. And irrespective of what aspect of cardiovascular disease your patient organization is involved in, and underlying in a very, very large number of cases, the underlying pre-condition to the existing condition, for example, heart failure very often has its origins in, for example, ASCVD. So our heart failure community should also be hopefully endorsing this program. And it's a co-creation between the Global Heart Hub and Novartis. And it's rooted in our shared objective to increase awareness of the burden of unmanaged ASCVD through a multi-year approach. And I'm hopeful that over the years, we will bring other partners on board to build the power of this message. And that I hope the Invisible Nation program will harness the power of patient organizations and advocates to ignite critical conversations with healthcare change makers and inspire action. And I think everyone would agree there can be no stronger voice than the voice of lived experience. And so we're appealing to our affiliates to engage with this. So the Invisible Nation project was launched, or program was launched a few months ago. And I'm glad to say that on the Global Heart Hub website, we have started to build a resource hub. And we have a short little video there, which we would encourage our patient affiliates to download and share. We have an initial press release, which outlines some of our aspirations. There's some fact sheets there in terms of the numbers and the burden of cardiovascular disease. This is all downloadable and easily shareable on all digital platforms. So the white flag has been raised on this program, and we are putting out a call to all the patient affiliates across our network and more to join with us on this journey of raising awareness of ASCVD and ultimately moving to a point where we can influence at government level across the world stakeholders to realize that this is a major public health issue. And given the fact that it is largely preventable, you can certainly intervene and improve the outcomes for those living with this condition, that this is an important imperative. And I leave it at that.
Thank you, Neil. Congratulations on the launch of this very important program. I wanted to ask you, if I might, a couple of questions. So I know that you talked about the overall goal for the Invisible Nation program. What are the short-term or long-term goals for Invisible Nation?
Well, I guess the very first short-term goal is to get the patient community itself fully engaged in the discussion. As I myself have noticed, the term ASCVD coming into parlance at conferences and meetings and so forth, I myself have struggled to understand why are the healthcare professionals making the distinction between ASCVD and CVD. And my own simple understanding of this now is that really under this umbrella, in simple terms, I see cardiovascular disease a big umbrella, and you have ASCVD and non-ASCVD. And if you take the ASCVD component of that, this is the this is the part of cardiovascular disease that's causing the greatest amount of harm, the greatest damage, the greatest cost. And with the exception of the likes of FH, which unfortunately you can't necessarily prevent, you can intervene early, of course, you can find it and treat it, but the majority of this ASCVD is preventable with a number of measures. But these measures need to be supported at the very highest level in terms of government strategies around prevention, education, and so forth. So to answer your question, short-term goal, let's get the patient community talking about it. Let's get them, engaged and enthused and light the fire that will hopefully create an inferno over a period of years.
I have one more question before I move to the chat and bring you all back in for the discussion. So, can any patient organization be part of this movement, or do they have to be part of the Global Heart Hub?
Not at all. Any patient organization can engage in spreading this message. Any patient organization can go to our website, Global Heart Hub, and this, as we say, is a resource we're building, and we're adding further assets and translations over time. But of course, if you are a patient organization working in the area of cardiovascular disease, we'd love you to come in under our umbrella. There's no fee or cost associated with affiliating to the Global Heart Hub. We just want you to be part of the family so that we can all share resources, share best practice, and together create a voice. Because ultimately, in all aspects of cardiovascular disease, what's going to bring about change, I fundamentally believe, is the patient voice. And it's increasingly becoming obvious that the patient is being recognized as a stakeholder for many reasons. And what we are missing, unfortunately, in the cardiovascular community is the capacity and capability right now to be really effective. So the Global Heart Hub is about bringing the community together and trying to develop this capacity and capability so we can act together with a single voice. And we know what can be achieved because we've seen it being achieved in other disease areas, cancer, rare diseases, you name it. There's plenty of examples of where the patient voice has been transformational.
That's fantastic. Thank you. Thank you, Neil. So I think we're going to move to the final portion of our session, which is the group discussion. I would invite all of you to share your screen so that I can ask some of the questions that are coming in from the chat. So I think this one I'd like to address to you, Professor Ray. So if LDL is a risk factor for ASCVD and the number of people living with it is on the rise, clearly that there is a gap somewhere. Where do you believe that gap is, or where the greatest gap is at a clinical level?
Yeah, so I think there are a couple of things. I mean, Magda talked about misconceptions around a few things, and this is really important. The first thing to do is separate LDL and cholesterol as a risk factor for cardiovascular disease, and then therapies. The reason you have to do that is that most of the people with ASCVD don't have extremely high levels of LDL cholesterol. It's just too high for them. That's why they've got cardiovascular disease. So when you take somebody like that, we know that for every 1 unit lowering of bad cholesterol, LDL, risk comes down by 22%. So if you do the maths, basically 2.5 millimoles lowering 100 milligrams per deciliter will reduce your risk by a half. Then there are those people where cholesterol levels are their main driver. So 1 in 311 has really high levels from birth, but your genes aren't your destiny. If you find those people, meaning you have to look, and if you treat those people with the right treatments, it's like putting money away in a bank and coming back 40 years later, you get a lot more benefit. Now, if you start saving later, you're not going to save up much money. So it's a very simple analogy, but that's where we need to separate this. Cholesterol lowering works in those at risk, but yet to develop disease. It works in those with established disease. And those with established disease gain much more because they start with much higher risk. Mm-hmm. It's like putting a seatbelt on. Seatbelts are beneficial. If I'm driving down my road at 15 miles an hour, little chance of me having an accident. So my benefit is relatively small. If I'm driving on the Autobahn at 140 kilometers an hour, if I run into an accident, I'm pretty well, going to need it, because should I have a problem, they're going to give me a big benefit. So that's a really simple way of thinking about it.
I have a follow-up question for you, and then I'm going to go to you, Magda, on FH. But first, the follow-up question. So is there complete consensus within the global medical community around the split between ASCVD and non-ASCVD?
Yeah, I think that's very clear, because we know what that means. It's very easy. If you've had a heart attack, if you had a bypass operation, if you had an ischemic stroke, that's ASCVD. The only kind of area that where there's a little bit of a debate is, let's say, for example, people scan themselves and you find furring of the blood vessels. Maybe it's not severe enough to have caused a heart attack yet, or maybe it hasn't caused any symptoms, but it's there. So if you think about it, do you want essentially your drain pipes to be relatively clean over the next 40 years? Or would you say there's a bit of scaling, there's some disease there? And so, if you find it, it's there, and we know they are more likely. It's like with buying, life insurance or insurance. Most of the time, you're not going to need it. But if it happens, you're going to be actually better off having that insurance.
Okay, great. Thank you. Thank you for that. So Magda, there's a question here about FH testing. How does one go about being tested for FH?
FH testing, how does one go about it? How do we get tested? Is this what you mean?
Yes.
Surprisingly, not many people know that it can be done very easily. You just, whenever you have your regular health checkup, you should make sure that your doctor tests for cholesterol. It's a simple blood test. And normally on your lipid panel, you would have the bad, the good, and the total cholesterol. I have to admit that until I started working with the FH community, I never paid any attention whatsoever to cholesterol. And learning from my own example, I started probing my friends and my family about cholesterol. People around me do not pay attention to cholesterol, do not ask their physicians to get it tested. And sadly, it is not a norm across most, and I can only speak for European countries. So I will plead, just like Neil did it earlier, anyone listening, please do take care of your own health. And if you do not know your cholesterol numbers, next time you go to have your regular check, or actually don't even wait for it, just have it done and ask to check your values. And then it's important to know that they might differ depending on your age and your sex. So I do invite everyone to check either the Global Heart Hub, CRE, or FH Europe website to know what would be the most optimal cholesterol numbers for you with this, with paying attention to the LDL, or so-called bad cholesterol levels.
I have a quick follow-up for you, Magda. So what would prompt someone to get their FH tested?
What would normally prompt you to get FH tested? Mm-hmm. Family history. If you have any history of your family members suffering from high cholesterol, premature heart attack or stroke, or any other heart conditions, please do ask. And I live in Switzerland, a country which prides itself in a very high level of public health care. You will not be asked by your doctor about family history, and you will not be necessarily asked to get your cholesterol tested. It is our responsibility. With patient engagement comes patient and citizen responsibility. It is in our hands. And so we need to ask for it. We need to be our own advocates.
Thank you for that. Neil, why do you believe that ASCVD has grown to be such a global public health problem? Where did we go wrong?
Well, clearly cardiovascular disease has been a major health challenge for decades, and there have been many public health initiatives over the years, the smoking campaigns and so forth, which have, clearly made some inroads, but now we have issues like global pandemic of diabetes, obesity, and so forth, which are again just contributing to the growth in the cardiovascular burden. But fundamentally, I believe the biggest problem is that governments internationally have not taken this seriously. For some reason, cardiovascular disease just hasn't received the same focus and attention as other diseases. And it's not a case of pitching one against the other here, but it's not a coincidence that when you do look at the disease conditions that move forward, there's a very strong voice behind those. If you take, for example, rare diseases, now I know Magda potentially could be described in the category of a rare disease, but in general, the rare disease community has been very effective. I mean, when you consider in many areas of rare diseases, they have succeeded in getting funding for orphan drugs, just for a small number of people. And I don't begrudge these people, nor do I suggest they shouldn't get it. Cardiovascular disease, accountable for over 30% of all deaths globally, and the biggest contributor to chronic disease. The reason global health systems are crumbling is because of the burden of cardiovascular disease. Why is it that we're not having an impact? I fundamentally believe that what we're missing is actually the patient voice. And until the global hub was set up, this voice didn't really exist in any shape or form. And so I'm hoping that if people can join with us in this belief that if we join together, the lived experience, which is really a scary experience for those who've had these conditions, can bring about the change that's necessary.
So you did talk about change at a policy level. Can I ask you, where do you, I mean, it's very broad, it's very big. Where do you recommend that patient advocates who are interested in getting involved in Invisible Nation, where do they begin?
There's so many. Okay, we've got to start at the basics. So what we want to do is we want patient groups to at least start discussing among themselves, what they see, what they understand, educate themselves. And then ideally, we get these groups to join forces and to have conversations with influencers. Now, what's an influencer? That could be their doctor. It could be it could be their specialist. It could be opportunities that they create or they take. But if you look at, for example, Magda is describing the circumstances with regard to FH, and I just look at the Irish context where I'm living. We do not have any strategy for FH in our country. We do not have a screening program. We do not have a care pathway. We have a handful of specialists who are there almost of their own volition. They're not officially providing a service. And so in this century, when we have 1 in 300 people with a lethal condition, and nobody has any reason to think that we should be organized in trying to reduce what is inevitable, either death or disability, it just defies belief. And so I think we have to organize. That's the short answer, and it's not going to be an overnight win. We have to organize, and on the other hand, while we're organizing, we need to start building our army in terms of capacity and capability. I mean, when we talk about patients, sometimes people talk about patients as if they're this little sort of object in the laboratory that we look at and we observe. Patients are people like you and me, and very many patients are very articulate, very well educated, and they find themselves as a patient by default. And by virtue of the fact that they are vulnerable, they are the weakest link then in the ecosystem of healthcare. So what we now need to do as a patient community is to start identifying our best possible ambassadors or advocates and give them the skills and the tools to start making noise and start opening conversations with influencers and decision makers. And over time, we will achieve.
Thank you. I know, Magda, you wanted to add something.
Yeah,
go ahead.
I think it's extremely important to set already the scene. I think Neil and the Global Heart Hub is paving the way, taking a bigger, wider approach. And this is why, obviously, we need to be very mindful as well, as both of gentlemen said previously, FH specifically or elevated LPLA are slightly different. Those are genetic. They might need a slightly different or separate path to resolving the issue. And I take a lot of pride representing our patient and citizen community to highlight that actually together with experts, we build this collaboration. We managed to submit to the European Commission best practice portal a best practice on screening from 5 countries. So examples of national pathways and examples of clinicians working with patients and patients working with clinicians, societies and policymakers is happening. It is just not happening at the right pace. It's happening too slowly. We need to be more agile as a community. We need to collaborate, pair, and we need to complement so we do not double the efforts. And that's why it's so important that FH Europe as an umbrella organization for genetic lipid conditions collaborates with Global Heart Hub when we talk about wider CVD, but then we can borrow and steal and borrow whatever the Global Heart Hub is doing to implement and enhance even better what we've started on a European level, going to the European Union and working with the politicians. And I just want to add, a lot of FH Europe members are members of the Global Heart Hub and vice versa, which is extremely important and demonstrates the need to collaborating in a complementary way. And again, Professor Ray and his society and the Global Registry is part of that wider movement.
Neil, I'll let you respond, and then I've got a couple of questions I've got to get to Professor Ray as we're running out of time.
I think what Magda's saying, 2 things are very important.
Yeah.
Number 1 is we must never take our eye off the ball on FH. So it's a standalone condition. It requires a voice and advocacy. Mm-hmm. Absolutely no question about that. And if there's any sense that the ASCVD agenda might take away from it, I would actually turn it the other way around and say the ASCVD debate should support FH, because in a strange way, when we do get to the point where we're well informed and with our guns loaded and we get to the decision makers, arguably the quickest wins should be in the area of FH, because we can identify these people and we can treat them. So if it was to use the FH as an example of what we can do, what better example can you get? A screening program will identify people, you treat them, and you reduce death and disability. So I very much see it as running in parallel in terms of never lose focus on your agenda, but at the same time joining forces, and particularly in FH as an exemplar of how we can bring about change. It's so much harder to find the 40% of the population that are currently living with ASCVD, undiagnosed ASCVD. That's a bigger task. So starting with a defined market, so to speak, should potentially be the way forward.
Thank you. Thank you both. I'm going to shift the conversation back to some of the questions that we're getting about the disease, about ASCVD itself. So Professor Ray, could you explain, and I've got a follow-up after that, after this one. So how effective is diet in reducing a person's risk of ASCVD? Are statins always necessary?
Yeah, that's an important question. So the key thing about all lifestyle interventions is you need to start it early enough. That means you've got to be able to better and identify people at risk over their lifetime. And if you make small changes in diet and that achieves reductions in cholesterol and blood pressure, then that's absolutely fine to do that. But you're going to have to run that for the next 40 or 50 years. Now, if you start doing something late, that's when we think about medications. But to the point, for example, of genetic conditions where even with a good diet and lifestyle, you are not going to be able to normalize it. So if you think about it, one way of thinking about it is If I have one leg shorter than the other, I can have the perfect back posture and I'm still not going to be able to walk straight without a prosthesis. So you do need that bit of support. So diet and lifestyle won't fix those genetic conditions, and medications are going to be needed.
So somebody, when you were presenting at the start, somebody asked if you could please define aggressive treatment in secondary prevention.
Yeah, so in terms of secondary prevention globally now, we should be bringing blood pressure levels down below about 130 millimeters of mercury. We should be bringing bad cholesterol or LDL levels down below 1.4 millimoles per liter or 55 milligrams per deciliter. And that's because these people are on such an accelerated trajectory. We have to basically treat all risk factors aggressively. And with that, inevitably, we have to think about using combination therapies because it's just mathematically impossible almost to do that with a single therapy approach. So some people we can get there, others we can't with a single agent.
So there have been a few questions about lipoprotein A, also referred to as Lp(a). So how does it fit into the ASCVD equation? Can you, Professor Ray, explain what it is?
Yeah.
And then perhaps, Magda, you can build on that and explain why it's important to people who have FH.
So it's a cholesterol-like particle. So it consists of an LDL-like protein with another part called apolipoprotein A attached to it. It's inherently genetically determined. So diet, lifestyle, all of these factors don't change it. Your levels remain remarkably constant throughout your life, which is why you just have to measure it once. 5% of the population have levels above about 70 nanomoles per liter, and risk starts to go up quite markedly. Doesn't mean everybody develops heart disease now. So how do we find it? In the same way as FH, if you've got a family history of heart disease early in life, if you have, for example, high bad cholesterol levels, often within that, because LPA is captured within that, unless you separate and measure that separate, you won't find those cases. And there are some people who will have familial hypercholesterolemia, or there are certain ethnic groups that will have higher levels of this, and it increases your risk of ASCVD. It also, and strokes, so heart attacks and strokes in the form of ASCVD, but also heart valve disease, aortic stenosis. And there are certain populations like people of Afro-Caribbean origin, Middle East, Eastern origin, they tend to have higher levels as well.
Magda, would you like to build on that? So why it's important to people who have FH, and
yes.
Should there be screening for it?
Yeah. So as Professor Ray already mentioned, people who already have FH might very often as well have elevated Lp(a). It doesn't necessarily mean that FH equals elevated Lp(a). You can conversely, you can have elevated Lp(a) without having FH. Why is it important? It is one of those conditions, CVD risk factors that we advocate for. It's genetic, as previously said. Why is it important for our community? Actually, building on this best practice and experience that we have gained advocating for pediatric screening, early screening and detection, we can bring that expertise for testing. Here specifically, we're talking about testing. Sadly, and again, I can only speak about Europe, there is no testing today widely applied. The reason for that is very, very simple. There is no officially available marketed treatment for elevated Lp(a). However, I would love to leave the audience on a positive note. There is a lot happening and hope is on the horizon, and there will be treatments coming very, very soon. That's why we as a community, again, need to gear up and prepare the necessary stakeholders, patients, citizens, as well as clinicians, policymakers to get ready. So once the treatments are available, we can start helping those people and preventing the unnecessary consequences of the condition.
So on the treatment discussion, somebody asked this one is addressed to you, Professor Ray. What is the best way to overcome a person's resistance to taking statins? Some individuals have a very strong belief that statins cause severe side effects such as joint and muscle pain.
Yeah, so I think we've got to get better at explaining risks to people. If you just say to people, take these drugs and medications, that's not a really good way to start. So doctors have to get much more. They have to spend time. It doesn't just have to be doctors, other healthcare professionals, and therefore try and explain what the potential benefits are. That's the first thing. The second thing is that also to say that, the number of times you might hear that doctors are making me do X or Y. No, have a conversation with patients, say, we're not making you do anything. You can stop this at any time. But then if that happens, you might then have to think about how you're going to change that risk, believing that you wanted to do something about it in the first place. If you didn't care and it wasn't important to you, maybe that doesn't matter so much. But trying to explain to people that there may also then be alternatives, that it's part of shared decision making, that we don't know how individual people are going to react. The side effects are far less common than people believe. 72% of those symptoms actually disappear with changing medications. And actually, if you gave people a dummy tablet with no active medication, they might have the same perceived symptoms. So not all of it is essentially caused by the drug. It's what we call the nocebo effect, because there's so much, noise around statins. You may perceive symptoms simply by virtue of the fact that you are taking it. So nobody's going to leave the patients alone. We're going to work with them to find what is right for them. Fortunately, now there are so many advances. There are lots of different things that we can do. And it's so different now than it used to be. So we're going to work with them. If something doesn't work, then we can remove that, look at alternatives, and do the best we can as part of shared decision making.
Speaking of advances, my final question here in the chat is, are there new treatments on the horizon which will hopefully increase survival time?
Yeah, so I think the point about, for example, Lp(a), as Magda was talking about, there are treatments that will specifically target Lp(a), but we lower risk by treating all risk factors. If you lower LDL, blood pressure, stop people smoking, better control diabetes, you will reduce the risk of ASCVD in somebody with a high Lp(a). And in the future, we can target that. The key to increasing survival time is how early you start. So if you start late, there are only a small number of life years left that you can shift. Think about it. You're at the top of a ski slope, course correct a little bit. I'm going to miss it by miles if there's a rock at the bottom. If I'm 10 feet away from that rock, I'm going to need a massive course correction. So, that's the way of kind of thinking about this. And there are plenty of different ways of doing this that will be more convenient, that will be much better for patients in terms of long-term compliance and adherence.
I wish we had another hour and a half to continue the conversation, but I'm being told that I have 60 seconds to wrap it up. I do have two slides that I would like the participants to walk the participants through. Before I do that, I thank each of you for your contribution today. Thank you immensely, incredibly insightful. And I hope that we do have the opportunity to meet again and to continue this discussion. Clearly, there is a need to do so. So with that, I'm just going to quickly, if you bear with me for 1 second here. So there we go. So as you're heading into the break, do if you're able to join for a healthy heart break. If you've got the time for a short meditation session or exercise class, simply click on the agenda part of the of your login. Otherwise, you can continue to look into some of the resources that are available. I know that there's a wonderful amount of resources available that you can see right here. In that, you can just click on this little tab right there. If you don't have time during the break, then you can absolutely go back to these resources that will still be available to you following today's event. And finally, please do share your hashtag just one thing. Again, it is just one thing that has inspired you over the past 2 days, or perhaps during this discussion, something you want to share with your community, or something that you've learned that you plan to act on. And we all know the power of social media. So if you can bring it into social media and use your platforms, and please do not forget to tag the Global Heart Hub. We've been hearing a lot about the word movement. The best way to create a movement, or the easiest way to create a movement, if we get it going, is through social media. So with that, I would like to wrap up this session. Again, thank you all for your time and for your participation, and I look forward to the next one.